1. Okay, chapter 10 about muscles. And so, first of all, we talk about the microscopic nature of muscles and the physiology of how a muscle actually contracts, because that's really all that muscles do is contract. And then we'll learn the anatomy of the different muscles in the body. I always like to show this picture. This is a good story. You guys are all going into some medical field. And back in the day, I was able to be able to afford to fly 10 people down to Mexico and go down there and do surgery in the mountains of Mexico, a little outside of Oaxaca, Mexico. It's very poor, very rural. But Northwest Medical Teams, an organization here in the Portland area, has gone down there and built a clinic. It's actually a clinic and a school where they train kind of first providers. So they take one kid out of each town and bring them into their clinic and teach them about being a midwife, teach them about clean water, teach them about sewage and how to deal with sewage, and teach them about inoculations and shots. And they're the only health provider any of these communities have ever had. And so they try to pick the smartest kids to do it. And it was just a real pleasure. They also had a couple of operating rooms that they that are there for American surgeons to come down and do surgery in. Anyway, so this is me back in the day. This is my boy. He's now 40 years old and teaches school. This is Jay Hoffman. Jay was an ophthalmologist, an eye doctor out in the Dalles, and he went along with me to do eye surgery on people, mostly to do cataracts. And, in this country, when you get to where you can't read the big print, you go in and get your cataract fixed so you can read everything, right? Down there is no health care. People, unless they have money, they cannot even see a doctor in most of Mexico, especially in southern Mexico, because the government in Mexico City has always kind of looked down on these native indigent folks that live down there in the mountains of southern Mexico. They have virtually no roads, they have no health care, no hospitals, no public hospitals, nothing. I mean, if you get it, you die from it. And that's why Northwest Medical Teams has worked down there. Anyway, this is one morning. We were driving out to the clinic to work. This lady works for Jay. She's an ophthalmology surgery technician. So is this one right here. This lady here is a ER nurse. That's Dick Onis. Dick is was the head OR nurse in the Dalles for many years. This girl worked for me. This is Randy Stewart. He was a nurse anesthetist. He came with us to put people to sleep. So it was really a great group, and we worked all week. And one day, towards the end of the week, I was sitting there, and we were closing up a case. And this was a nun we were operating on, a Catholic nun, who had had a hernia her whole life, and it stuck out about that far. And she came, and of course, when you saw her in her habit, you put her to the head of the line. We're going to operate on her. We're going to fix that. And we did. And so we're sitting there, and me and Dick are finishing up. I did most of the surgery with him or with one of the other nurses as the assistant across the table from me. And Randy walks in, and Randy says, "Hal, you're not going to believe what's out front. But there's a guy with a dead foot, and we're going to have to do an amputation." And I said, "Okay, keep him in PO. Don't give him anything to eat or drink. We'll operate on him next or later today." And this is Randy talking to him. This is the man here. There's his foot. His kids have brought him. They had been taking him to hospital after hospital, trying to get somebody to take care of him, but because they had no money, they got no care.
Did they speak Spanish, or how they understand you?
We didn't speak. Several of us did speak Spanish, but I don't. And actually, the language they spoke was Michoacan, from the Indian tribes down there. But we had plenty of interpreters around. this was his foot. It was dying, obviously. He had diabetes and vascular disease, and his toes were all dead. Obviously, a couple of them had already fallen off. You could see the redness starting to advance up his leg. He needed that off. Well, anyways, I'm standing there in the operating room, and we're closing up, and Randy came in there and told us that. Dick looks at me and he says, "Hal, you're not going to believe this, but I didn't bring a saw. We can't do an amputation." I said, "Really?" He says, "I brought 9 boxes of surgical instruments, but I did not bring an amputation saw. I didn't even think about it." I said, "Okay, we'll find something." Now you have to realize that all we had was a sterilizer that was this big around and about that long. So all the instruments for each case we would wrap up in little cloth packs and shove them in that sterilizer to sterilize them. Well, we went through all the storerooms there looking for a saw, and this is the one we found that we could take apart. We could take the blade off of it from the handle. See, there's 2 screws in it right there. And then we scrubbed it all down with scrub brushes and stuck it in the sterilizer and sterilized it. So it was perfectly clean and at least had all the chunks of rust off of it. And we were able to take the man's leg off below the knee. This is him a couple days later. His leg ends right there now. And he's really short. These folks that live down there are very short. In fact, I would say he was about 4'9" at the most. I mean, we're talking really short. And so we had brought some crutches with us, and I'm using a saw to even cut the shortest crutch we had off to make it shorter so that he could use it. And we put him up in the truck. That's a truck that family had borrowed to bring him to the clinic. And as we're loading him in the truck, the daughter here says to me, "Well, doctor, we need his leg." And I said, "Excuse me?" She says, "Well, it's very important that when we bury him, when he dies, that his whole body is there. So we need his leg." And so I turned to a couple of nurses. I said, "What do we do with the leg?" You know? And they said, "Well, we threw it in the garbage." And normally in the hospital, you would send it to the pathology department, you know, and they would cut it up and look at it under the microscope and all that. But we didn't have any such thing, so we just kind of got rid of it. So we went out and fetched it out of the garbage without telling them. We wrapped it up in about 3 plastic bags and then a whole bunch of duct tape. And I handed it to them, and they left with his leg, as well as him. So that was kind of a cool story. Okay, back to Miss Frizzle and the muscles. Children were sliding on a muscle. From here, we'll return to the bloodstream. Way to go. Remember, we have already talked about muscle in some way. We know there's 3 kinds of muscles. There's skeletal muscles, there's cardiac muscles, and there's smooth muscles. All right? Basically, in this chapter, we're mostly going to talk, 95% of the time, we're going to be talking about skeletal muscle. That's the muscles that we have control over. And as we talk, I'll mostly be referring to this muscle right here, because I can point at it. It's visible to some degree. All right, so remember we got the 3 types. Muscle itself is a primary tissue type. There's 3 other types under it there. When we talk about the skeletal system or the skeletal muscle system, we're talking about just the skeletal muscles. We're not talking about those others. What are the functions of the muscular system? Well, it's to produce skeletal movement. Without muscles, we couldn't move anything. We couldn't walk. We couldn't stand up, so it maintains our body position. Supports all our soft tissues. Guards our opening. It closes our mouth. Closes our eyes. Closes our rectum. Those are pretty important things. It guards all those openings. Muscles, we know from day 1 of 231, helps us maintain body temperature by
Shivering, right? Muscle can shiver if we get cold and bring our temperature up. And muscles also store nutrients. What's the main nutrient that is stored in muscle?
Protein.
It's protein. That's what makes up muscles. But what's the chemical?
Amino acid.
No.
Glycogen.
Glycogen, exactly. Glycogen is the fast use metabolite that we store in muscles. Okay, well, it involves more than just muscle, although that's most of it. Muscle tissue, we will call them muscle cells, but really, I think mostly we call them muscle fibers. Please remember, for the duration of this chapter, that muscle cell means exactly the same thing as muscle fiber, okay? And muscle cells can be very big, in other words, and very long. In other words, one cell, one fiber, can go from one end of the muscle to the other end of the muscle, and it can be 12 or 14 inches long, okay? That's one cell. Now, it's going to have thousands of nuclei in it, and it's going to be lots of repeating patterns, which we'll learn about, but the fact is, muscle cells, this is the cell, same as muscle fiber. There's connective tissues around those structures that hold them together. You guys have already seen in lab, I think. No, you haven't. Never mind. The connective tissues around muscles, kind of the fascia, the loose tissues that are there. If you've been to lab and seen any of the dissected cats yet, you'll know what I'm talking about. They have nerves running through them. That's what tells them what to do. And they clearly have to have blood vessels because they need a lot of blood. They need a lot of energy. They need a lot of oxygen because, let's face it, muscles can work hard. Okay, so this is a kind of an organization thing. I could turn one light on, I guess. Would y'all like a light on? Maybe it'll keep you awake.
I wish you could make this
Not that I've
bigger.
noticed anybody sleeping yet. What?
I wish you could make these bigger. I thought I had good vision. But I don't know.
Well, then come over and sit closer. That's a problem. I mean, there's a room for a row of seats right across that, right up here even. Anyway, so this is a muscle. And that's what we're talking about here. This is the skeletal muscle. This is the organization of muscles. The muscle has connective tissue around the outside of it that we call epimysium. Epi, on the outside. Epimysium. And inside that muscle, as illustrated right here, there's a bunch of muscle fascicles. Muscle fascicles are little collections of muscle that are smaller, and the muscle fascicle, as illustrated right here, is surrounded by connective tissue called perimysium. And then the smallest unit is muscle cells, which we'll get to down here, and each one of those is surrounded by endomysium. Okay, so these are muscle cells inside of here, and they're surrounded by endomysium. So going from the muscle here, this is the whole muscle, to the muscle fascicle. Here's a muscle fascicle, and it's got tissue around it, which is called perimysium.
Phew.
And in that, there's muscle fibers, and then around each muscle fiber is endomysium, and that gets us down here to this last layer, last level. One dot here becomes this whole thing, and this is a muscle cell, also called a muscle fiber. And notice that it has myosatellite cells around it. It has all the nuclei are around the outside of it. There'll be a lot of nuclei in each fiber cell, tens of thousands sometimes, but they're always located out here at the edge. The cell membrane, which is this area right here, is called the sarcolemma. Muscle is called sarco. That's a Latin term, I guess. And so we have sarcoplasm, which is the same as cytoplasm, only it's in the muscle. We have sarcolemma, and if you know anybody that has a really bad tumor, it might be called a sarcoma. Sarcoma, is the name of a muscle tumor. Okay? So sarco, just think muscle. At the end of the muscles, the endomysium around each single muscle fiber, the perimysium around each single fascicle, and the epimysium around the entire muscle, they come together at the ends of the muscles to form tendons. Okay? And that's what does the pulling. Okay? So all the fascicles and so forth in this muscle here come together down here at the end of it, and it forms a tendon. The tendon then inserts into the bone to cause the arm to come up when this muscle here contracts, right? Okay. And what kind of tissue do we call a tendon? Dense, regular, right? Connective tissue. Now, some muscles actually insert into a ponderoses. It's a sheet of fibrous tissue. So, like our abdominal muscles insert into this. One of the things that it inserts into is this thing called the linea alba, which is down in the middle. It's a long aponeurosis down the middle. Nerves, remember that these muscles are all voluntary muscles, so they're all controlled directly from your brain and your spinal cord. These muscles do not move unless your brain says move. That's just the way it works. The blood vessels obviously are extensive because they have to carry lots of oxygen, lots of nutrients, and carry away a lot of wastes. And any of you who have lifted weights for a while, you get that burning in your muscles. Well, that's a buildup of the waste products, and that's why you eventually have to put the weights down and let them sit there and let the pain go away as it cleans out all those, as the blood flows into the muscle and cleans out all the waste products. Okay, as I told you, the muscle fibers are very long. How do they get to be like that? Well, you take a bunch of little cells that are called myoblasts. Remember blasts? Blasts are like stem cells, right? They come together, and these myoblasts are just like those osteoblasts and just like those chondroblasts and all that other jazz. These are going to form, they're going to glump together to form muscle fibers that are very large and contain hundreds of nuclei. So this is just a quick diagram to illustrate that. Here's a bunch of myoblasts. They're starting to clump together. Occasional myosatellite cell grabs on there to help control things a little bit and to form the connective tissue. Here's a bunch of nuclei, and they gradually get together to form these long muscle fibers that look like this. Now, remember when we were on tissues, we looked at it under the microscope, and remember it had this striped appearance, and we called that striation, striated. Well, now I'm going to explain to you why they look striated, and what is it that makes them look like they have stripes in them. And we're gonna find that that's caused by just a very orderly arrangement of all of the fibers that react together to make contractions happen. Dumb picture. Kind of repeat again. Please notice that the nuclei are always found around the edge. You'll never find a nucleus in a skeletal muscle cell out here in the middle. Okay? The nuclei are always around the edge. Now, out in the cell itself, in the middle of the fiber, you'll see a lot of these guys. They are mitochondria. And you would expect that muscle would have lots of mitochondria because it burns lots of ATP and lots of energy. So it needs lots of mitochondria. This is a light microscope at 612 power. You guys can all get more than that. You can get up to 1,000 power on your microscopes. And so you should have seen that. If you haven't, you need to look at it and see the striations. I told you that the cell membrane is called a sarcolemma, and it surrounds the sarcoplasm. And the important part about the sarcoplasm, important part about the sarcolemma is that it carries electric charges. Okay? In other words, it carries a membrane potential. And when an electric shock arrives down your arm from your brain up here and says, hey, it's time for you to contract, the way it sends that message out is by changing the transmembrane potential. That electric charge, that transmembrane potential, spreads around through the muscle cell, and it's that electric signal that then tells the muscle to contract. We're going to go through that step by step here.
Do you have a twitch that's like a misfire?
A twitch is a single fire of a single fiber. Yeah, I'm not quite sure your question.
Well, I mean, you ever like sat with your like leg like in a funny position and then you just kind of like your leg moved involuntarily?
Yeah, I think that's just a seizure.
Thanks for telling me.
Yeah.
I appreciate
It's nothing worse. It's nothing worse than cancer.
Feel so
Okay, so this is a further breakdown of this microscopic picture. And to get these kind of pictures here, we're not talking light microscope. You're not going to see this stuff here under your microscope. These are from scanning electron microscopes and electron microscopes that are 10,000 power and 25,000 power. That's how we know that this stuff I'm going to talk to you about now. So this is kind of a close-up of a piece of muscle. This picture down here would basically be, like one little stripe there worth. Notice the sarcolemma is the covering on the outside. And notice that the sarcolemma completely surrounds the cell, which means it can go from end to end of the muscle and have lots and lots of, nuclei in it. Here's the nuclei illustrated up here. There is no nucleus illustrated on this part of the picture here. But there are a number of mitochondria you see scattered through it. Okay? Coming in from the outside of the sarcolemma are these protrusions in that are called T-tubules. Here's T-tubules. They're illustrated in yellow here. They're just illustrated as a hole out here on the outside. But these T-tubules actually act mostly like sarcolemma in that they can carry this action potential. So this action potential, when it comes down the surface out here, it then dives down through all of these T-tubules and through all of these things, and that allows it to signal to all the muscle deep inside that, hey, it's time to contract. Okay? So that's what the T-tubules are all about. Now, these red little dots here that you see, those are myofibrils. Those are the actual proteins that cause the contraction, and there's basically two types of them that you need to know. One is called a thin filament, and the thin filaments are called actin, A-C-T-I-N. That's the name of the protein, actin. The thick filaments, which are illustrated in blue in this picture here, are made up of a protein called myosin. So myosin and actin are the two kinds of fibers that are going to react to make contractions happen. And as I finish this lecture, you're going to see me doing this with my fingers and kind of overlapping them. And what you need to think about is this is the actin and this is the myosin, or one way or the other, it doesn't matter. But you're going to see that the way they actually cause contraction is that the thin and the thick ones interact to each other, and they kind of climb over each other and cause a contraction to happen like that. Okay? So that's what we're illustrating here is with the actin and the myosin, the thin and the thick filaments. One other thing is you notice that there is all this blue stuff, it's actually sarcoplasmic reticulum. You guys remember sarcoplasmic reticulum. Well, notice that in muscle tissue, the sarcoplasmic reticulum is very, very extensive, and it's also very, very organized. Okay? So it's organized such that this is all sarcoplasmic reticulum, but notice that on either side of the T-tubules, there's a big clump of it here, and we call that the The terminal cisternae, thank you. Where is that? I know that's up here somewhere. On the top. Yeah, terminal cisternae right here. Okay, I'm sorry. All right, so here's a terminal cisternae. Here's a terminal cisternae. Here's a terminal cisternae. Here's a terminal cisternae. These terminal cisternaes and the T-tubules make up what's called a triad. Okay, a triad is 3, 2 terminal cisternaes and 1 T-tubule. Now, why are they paired like that? Well, remember, the T-tubule is what's going to bring in the action potential, going to bring the shock in, and the terminal cisternae is where the calcium is being stored that's going to be released all out into the tissues here, and when the calcium is exposed to these fibrils, that's what's going to cause contraction to happen. Okay? Okay, so going back through these a little bit again, the transverse tubules or the T-tubules, they transmit the action potential through the cell, and that allows the entire muscle fiber to contract simultaneously. The surface of the T-tubules, that membrane, is really just the same as sarcolemma. It just happens to be going down into the muscle, and thus it's called a T-tubule. The myofibrils are these bundles of filaments I already mentioned to you. The thin filaments are called actin, is the protein actin. The thick filaments are made up of the protein myosin. Sarcoplasmic reticulum are those blue things that I showed you. It's a membranous structure, surrounds each myofibril, and they help transmit the action potential inside as well as the T-tubules. They form these chambers called terminal cisternae. They're right up next to the T-tubules at either end. Triad, as I've already mentioned. What is the function of these cisternae? Well, the cisternae, their job is to concentrate the calcium. Calcium is the chemical that is going to make muscle contraction happen. Okay? We've already talked about calcium a little bit, and believe me, as we go through the rest of A&P, we will come back to calcium many times. Okay? Calcium is released out here into these sarcomeres to start the muscle contraction. What is a sarcomere? A sarcomere is one unit of a muscle fiber. So it's like from here to the next one right there. Now, I'll show you more pictures here in a second that will help with that. Here's the test question. The test question is, what is a sarcomere? And the answer is, the sarcomere is the contractile unit of muscle. Remember how the osteon was the functional unit of bone? Well, sarcomeres are the functional unit of muscle. The sarcomeres form this visible pattern, and that's what creates the striations. I'm going to show you that better in just a second. I'm going to skip that. I'm just going to go to this. This is really what a sarcomere looks like right here. Sarcomere can be defined not only as the functional unit of contraction of a muscle, but it also goes from what's called the Z line, that's called the Z line right there, to the next Z line, okay? Within the Z line, there are several bands. I like to just think of them as light and dark. They have all kinds of names for them, A bands and I bands and H bands and M lines and all that jazz. But the fact of the matter is, you notice when you're looking at the sarcomere that there's a dark layer here, and then there's 2 half light layers on either side, and that's what's going to cause the entire muscle to have these alternating areas of light, dark, which is what's going to create the striations. Here's a microscope picture of that, and you can see how incredible this is. How incredible man's technology is these days. This is a scanning electron microscope picture here. 64,000 power. 64 times more power than you guys have under oil immersion. That's a lot of power. We are looking at molecules here. Think about that. we're looking at molecules lined up together, molecules of protein. I would have never thought in my life we would be able to see molecules under the microscope. I thought seeing tissues or amoebas was pretty good. But here we are, we're looking at molecules. So these are molecules of myosin here, and these are molecules of actin that are going from here to here to here, and we're seeing these lines like I showed you on that picture before, and you can just see it so clearly. I'm just fascinated by it. This slide here goes back to earlier. The entire muscle is surrounded by epimysium. Muscle fascicles are surrounded by perimysium, and the muscle fibers themselves are surrounded by endomysium, or inside. How many of you have eaten pulled pork lately? Okay? So when you take a piece of pulled pork and you've got it hasn't been pulled yet, let's just say, sitting there as a slice on your plate, and you take your fork and you kind of start teasing it apart. What are you teasing apart? Huh? Well, it's muscle, that's for sure, but really you can't tease it down to the muscle fiber layer. You can pull it apart into fascicles, little fascicles. So each one of those little stringy things that you pull loose, that's a fascicle. Make sense? Any vegans in the crowd? Too bad, ladies. Too bad.
You've just destroyed my ability to eat pulled pork anywhere down the field.
Okay. That's probably a good thing for your heart, maybe. I don't know. Okay, well, there's some more pictures here. I think I've said all I need to say about these pictures here, so I'm going to skip that one. There's a couple other proteins that you need to be aware of, and I hope to have some little videos to show you, maybe in lab, of what these things do. Let's talk about these two right here. One is called tropomyosin. You should know about tropomyosin. Tropomyosin is a double strand. It kind of surrounds the actin molecule, and it kind of blocks access to the interaction points. It covers up the places where the little arms are going to reach on and grab onto the next fiber. That'll be better illustrated later in a picture. There's another one called troponin. Troponin is another muscle protein that is a globular protein, and it binds the tropomyosin to the G-actin. In other words, it's what really makes the tropomyosin move out of the way so that muscles can interact. Anybody in the crowd work on an ambulance or work in an emergency room? Troponin levels, you ever heard of it?
I was going to ask about that actually. Why is that what they measure for heart attacks?
Huh.
It's cardiac muscle.
Let me ask you the question. Why would we want to be able to measure troponin levels? See how much calcium? Not exactly.
How much the heart contract?
No. When muscle dies, that's the definition of a heart attack. Okay. When you've actually had an MI, that means that a piece of your heart muscle has died. When it dies, the muscle cells kind of explode, and they release all of the proteins that are in them. And indeed, there is troponin in it. And so then it goes out in the bloodstream. So now you draw a blood test, you take it to the lab, they run a test for troponin, and they say, yes, there's troponin in the blood. By the way, there's a lot of troponin in the blood, which means yes, you had a heart attack, and yes, it was a pretty good sized one. Okay? On the other hand, if somebody comes into the ER and you're not sure whether he had a heart attack, but he's had chest pain, he's had all the other symptoms, and you're worried that this is a heart attack, and you draw a troponin level and it's negative, that tells you they haven't had a heart attack. That doesn't tell you they're not in the process of having one, but at this point they have no dead muscle, okay? That's what the troponin, so you'll hear the troponin level a lot.
So it's only in heart then?
What?
It's only in
No, it's in muscle out here too, but it's rare that muscle out here just dies like it does with heart attacks. Good question. Okay, now let's do a little bit more on this. Here's a nice set of protein filaments. These are the myosin fibers, and the red ones are the actin. Remember? Okay. Now, the way that muscle contraction happens is that actin is this myosin is this big thick fiber, and notice that it has these little arms on it. Okay. And the way that muscle contraction actually happens, I'll illustrate on this one right here. My hand is now one of those little arms, okay? So here's the actin, the myosin rather. It's got these little arms, and they're flicked out there like that. And what happens is they straighten up, they move over a little bit, they grab on to the red one, they grab onto it, and they cock the head. And in the process of cocking the head, it moves along it. So then it does it again, does it again, does it again, and slowly, and actually pretty quickly, the muscles actually shorten because they're grabbing onto each other. Not just one, but at every level, okay? Now, this muscle is illustrated at this point at rest. And please, for my finger example, you see that there's a pretty good contact between my right fingers and my left finger. They're pretty much like that. Now, if it was completely contracted, it would be like that. Now, if it was like that, it couldn't shorten anymore, right? So this muscle here would not be able to contract much at all. By the same token, if the muscle had been overstretched and it's out to here, once again, even though it's trying to interact and trying to contract, it really can't because there is no touch between the blues and the reds. I think I've got a better picture here. Here's what happens if it's completely slid in. You know, it can't really slide anymore. It doesn't have one of it undone. I'm sorry. Okay. Now, what I'm going to try to talk you through, and I think video does it better, is talk you through this. How does a muscle really contract? And the way that it really contracts is, first of all, there is this electric signal that arrives, which we're going to call an action potential. And that action potential is going to get into the cell. It's going to travel down through those T-tubules to the cisternae. It's going to cause the cisternae, which are, remember, sarcoplasmic reticulum, that have a whole bunch of calcium stored up in them. It's going to cause them to just release that out into the tissues, and the calcium is going to trigger this interaction of the thick and the thins and cause the contraction to happen. To do this, it takes a lot of ATP. This is an active reaction that takes ATP. That's why the mitochondria and lots of blood supply. As it does that, it's going to cause tension, and the muscle is actually going to be able to move something. All right, but let's go back a step. Let's go back to where the electric signal comes from your brain down to the muscle, okay? Well, it does that by this action potential. This is another electric shock that's called an action potential. It travels down this nerve, and when it gets to the end of the nerve, it gets to the end of the axon, it reaches what's called a synaptic terminal. A synaptic terminal is the little end of the little nerve buds, and in those nerve buds there's a stored up neurotransmitter, and that neurotransmitter in muscle tissue is called acetylcholine, ACH. it causes the acetylcholine then to be released out of the end of the nerve into this little cleft, which is called the synaptic cleft, which is between the nerve and the muscle. Okay? So it's the acetylcholine that kind of goes across that gap and stimulates the muscle, which is called the motor end plate. I'm looking for a better picture. Well, let's go back to that one just for a second. Okay, let's look at this part of the picture up here. So here's this motor axon that's in your brain. It's going to tell your muscle to contract. It sends the signal down the axon. It gets to the end of the nerve, which is called the motor. This whole area is called the motor end plate, also called the neuromuscular junction, because this is the junction between nervous system and muscular system. Okay, and it comes to these little buds like this that are basically the synaptic terminal right here. And notice that the synaptic terminal has a mitochondria there in it. It has these little red dots, which are little vesicles. Remember vesicles from back in 12? These little vesicles are full of ACH. And it causes those little vesicles to move to the edge, move out here to the edge of the nerve, and then they fuse with the wall, and they release their contents out into the gap, and we call that process exocytosis, right? Exocytosis or exocytosis. Okay? And that releases the acetylcholine out here into this brown, in this little diagram here, it looks brown. That's the gap. Okay? And that acetylcholine is then going to go across the gap to stimulate the muscle. Let's go through another, I've got a better picture here. All right. So here it is. Step one. The action potential arrives. Now, the action potential in these diagrams, they illustrate as the neurolemma, which is the outside layer of the nerve cell here, turns red, okay, as this action potential arrives. When the action potential arrives, when the shock arrives, it causes these vesicles to move up to the edge and spit these balls of acetylcholine out into this gap right here. Okay? This is the muscle cell on the other side. That's the muscle cell on the other side. And notice that as with most neurotransmitters, the way they work is they activate gates, right? They activate a gate and allow something then to flow in or flow out of the cell and the cell membrane, through the cell membrane. Well, indeed, that's the case here. So these little bits of acetylcholine are going to come across this gap, and they're going to lock on to these very specific receptors over here, which are basically acetylcholine receptors, and they're going to cause the membrane porosity over here on this side to open up and allow a bunch of sodium to flow in, which is then going to change the charge, change the action potential of this membrane on this side, which is the muscle membrane, which is the sarcolemma, as you can see here. It's going to change the action potential of the sarcolemma, and that action potential change is going to spread across the wall of the muscle, go down through the T-tubules, cause the calcium to be released, and cause the muscle to contract. Okay? Now let's go through it step by step. All right, here it is. The action potential arrived. Here, the red comes down. It causes these little vesicles to move to the side and exocytosis to occur, causes it to release these little molecules of acetylcholine out into the synaptic cleft, or the gap. They come across the gap, and lo and behold, they lock onto these receptors. Here they are here. They don't have anything attached to them. Nothing's really happening. But once little acetylcholine becomes available, it locks onto these pores, and that then changes the porosity of the membrane and allows a bunch of sodium to flow into the muscle cell over here, which changes the action, changes the charge, changes the action potential. Eventually, enough charge changes, and this now becomes an action potential. It becomes positive. That's correct, inside. And now we have a charge set up in the wall of the muscle cell. So now we have an action potential that used to be up here in the nerve cell, but now it's an action potential in the muscle cell, and that action is going to spread through the sarcolemma, going to go down through the T-tubes, and that's what's going to cause the muscle to contract when the calcium is released. Okay, now, one more step. What are these little yellow moons? What are they all about? Well, those yellow moons are what's called acetylcholinesterase, ACHE. You need to know ACHE. Because what they do is, very quickly, they come over here and they grab onto these acetylcholine molecules, these red balls, and they deactivate them. Like this. So here comes the acetylcholinesterase. It grabs onto these molecules of acetylcholine. It breaks it down. And when you break down acetylcholine, you get acetyl and you get choline. And guess what happens to those things? They get retaken up back into the synaptic, the nerve up here, and they get recreated into new vesicles, so it'll be ready to do it again the next time a shock arrives. So what's the significance of ACHE, you may think?
They recycle the thing. They help to recycle the
It helps to recycle it, but it also stops,
having too much.
it stops the flow, and it stops the
release of calcium.
Yeah. All right, so here's the clinical story. We were a pretty small hospital out in Dallas, but about once every 3 or 4 months, here's what would happen. Put a patient off to sleep. Usually when you put a patient to sleep, the first thing you do is you give them a shot of curare or some paralyzing agent that paralyzes them, okay? And you do that because you don't want them to fight you while you're trying to get the tube in their throat, and so you can breathe for them throughout the whole case. And what would happen is you'd put somebody off to sleep, and they would give them the paralyzing drug, they would intubate them, they would turn on the gas, the anesthetic gas, which is what would keep them asleep through the whole operation. Normally, the paralyzing drug would wear off in a matter of 2 minutes, okay? But now the anesthetic drug has taken over, and that keeps them asleep, okay? It also keeps them paralyzed pretty much. All right. 2 hours later, case is over, and you're putting in the final stitches, and the anesthesia guy says, "Hey, Dr. Sessions, he's not moving. He's still paralyzed." And what's going on? We only gave him 2 minutes worth of paralyzing drug. Why hasn't the effect gone away? Well, the answer is, since you probably don't know it, is that certain patients don't have enough of this stuff here. They have an acetylcholinesterase deficiency. Acetylcholinesterase deficiency. They don't have enough of these yellow moons, so that in 2 minutes they didn't break it all down. And because of that, these channels stayed open, and this muscle over here continued to be not working. Okay? 2 hours later, they're still not working. So what do? Well, the patient can't breathe. He can't move a muscle. Still got his endotracheal tube in. You hook him up to a bag. You take him up to the intensive care unit. You put him on a ventilator. You let the machine breathe for him. And usually 8 to 10 to 16 hours later, they can breathe on their own. They make a full recovery. Okay? So there are patients, and there's a bunch of them out there who don't have enough acetylcholinesterase, and that's really the only time you ever know that. They can still run and they can jump, and their muscles work fine on a regular basis until you slam them with a paralytic agent that basically blasts it all away, and then it releases a tremendous amount of this stuff, which causes this, which really causes the muscle to go into spasm, but when you're looking at them, the patient is paralyzed, and that's really what you wanted. Okay? All right. What? That's I think you can now, but it's real expensive to test for, and it's very rare, and best way to check for it is to ask the patients, has anybody in your family ever had problems with anesthetics? And if they do, then you might test them. But I don't think you just don't test everybody because it is pretty rare. I think I'll stop right there. We'll finish this up over in the lab. I have your tests. We'll go over the tests over there if you want to. Maybe I can hand them out. No, I won't. I'll just hand them out over there. Okay, can I get all that stack of papers? Thank you. Any more? Thank you very much for your input.
Are those the evaluations?
These?
Yeah.
No.
What were those for? I didn't get any.
You can give it to me later.
Okay.
Thank you. It's a questionnaire. We're trying to come up with a video to help students in 112.
Okay.
What did you wish you knew before you went into 112
Okay.
that you didn't know?
Okay. Thank you.
So we're doing a cat today, right?
We are?
So I have this thing I want to tell you. So you see this scar right here I got cut on some glass trying to get it and like it was so deep that I could see my tendon.
Uh-huh.
Every time that I would go like this, I could just see the tendon moving, and I was sitting in the emergency room and